CNS infections, like bacterial infections. Bacterial meningitis is acute CNS infection, while tuberculosis, neurosyphilis is chronic CNS infection. Viral meningitis, herpes simplex encephalitis, fungal cryptococcal meningitis, parasitic infections like toxo-neurocysticercosis, cerebral malaria. Infection of the CNS is an extremely common clinical problem. There are 4 main patterns with associated inflammation. Either patient in CNS infection may have meningitis, which is inflammation of the meninges. Meninges and its inflammation can be limited to leptomeningitis, which is inflammation within subarachnoid space involving the pia and arachnoid matter, and it's common pattern of meningitis. While in some inflammatory disorders, like for example sarcoidosis, you can have pachymeningitis, which is dural involvement with inflammation. Localized CNS infection like cerebritis and cerebral abscess, while generalized and diffuse brain and spinal cord inflammation is called encephalitis or myelitis. And when meningitis and encephalitis is combined, it forms meningoencephalitis, which is combination of infection of the brain matter as well as the inflammation of the meninges. It can be seen in TB, it can be seen in viral infections. This is a picture showing the normal brain covering versus these abnormal brain coverings with you can see inflamed meninges in meningitis along with milky white CSF, while on the normal side you can see there is no inflammation of the meninges brain covering. Focal CNS or brain matter disease like abscess, either single or multiloculated abscesses can be seen. Epidural, subdural abscesses, it's also commonly seen in CNS, chronic CNS infections as well. So different syndromes with common causes for that. For example, for meningitis, bacteria is a common cause. Along with bacteria, you can see some viral infections can also cause meningitis. Fungal infection can also cause meningitis. But commonly in our setting, bacteria is most common. While for encephalitis, if you can say isolated encephalitis, viral encephalitis is common presentation in neurology. But in TB, you can have also encephalitis. Brain abscess, again, bacterial infections are common cause of brain abscesses, either iatrogenic or through contagious spread. TB also causes brain abscess. Different routes of CNS infection. Common is again hematogenous route, which is the route for most of the infecting organism for brain disease. Contagious spread from paranasal sinuses, from middle ear infection, from face. It is common with bacterial agents. Again, direct inoculation through trauma or sometimes through surgery. Bacterial infection are common. Via nerves, the infection may spread, for example, with herpes simplex, varicella zoster, and rabies virus. What is subacute meningitis? Is the symptoms of meningitis that last for days to weeks. Chronic meningitis are the symptoms that last for more than 4 weeks. This is what that will be discussed today. And recurrent meningitis is the meningitis in which there are multiple episodes, 2 at least episodes of meningitis, which are weeks to months apart, with full clinical and CSF recovery between those attacks. So chronic CNS infection is defined as that lasting for 4 weeks or more, and it's a complex entity with both infectious and non-infectious causes. We will discuss only infectious causes, not non-infectious causes. Non-infectious causes, for example, in patients with inflammatory disorders like sarcoidosis, associated with malignancies, you can have some inflammatory problem in the brain lasting for more than 4 weeks. Patients with chronic meningitis usually have a subacute onset of symptoms, including fever, headache, and vomiting. These symptoms can remain static, they may fluctuate, or they may slowly worsen. So chronic meningitis results from ongoing infection, which is commonly seen especially in patients with skull fracture or prior neurosurgery or surgical intervention. Chemical causes such as The rupture of the epidermoid cyst or installation of chemotherapy, for example, sometimes for various CNS malignancies. Malignancies, autoimmune diseases, or bacterial infection of lower virulence can also lead to chronic meningitis. Recurrent bacterial meningitis is associated with defects in the protective barriers to the meninges, especially dura mater, and it is commonly seen with surgical interventions. Recurrent bacterial meningitis can also be seen with congenital cranial or spinal sinus tracts, basilar skull fractures, or following CNS surgery. So, coming to infectious causes of chronic meningitis, among bacteria, the common causes include Staphylococcus, actinomyces, Whipple's, brucellosis, leptospirosis, nocardia, parameningeal infections. Mycobacterial infection with TB is common cause of chronic CNS infection. It is the most important single cause of admission with chronic CNS infection in our department, in neurology department, especially in this part of the world, South Asia. You will find the most common cause of chronic CNS infection is TB, chronic TB meningitis. Fungal causes, Cryptococcal pneumoformans, Aspergillus, Candida, Histoplasma, coccidioids. These are common in patients, especially with immunocompromised status. Parasitic infections, again, more common with immunocompromised status, especially toxoplasmosis, cysticercosis. Viral causes, SSPs stand for subacute sclerosing panencephalitis, which is due to measles infection acquired in childhood, and mumps, HIV, herpes simplex, progressive multifocal leukoencephalopathy. Common symptoms and signs associated with chronic CNS infection include fever, headache, nausea, vomiting, seizures, encephalopathy, and signs of meningeal irritation, and really focal signs sometimes especially may be found, for example, focal weakness of the limb or cranial nerve palsies, especially third nerve palsy, seventh nerve palsies. They can be found with chronic CNS infection involved with meningitis. In recurrent meningitis, examination for dermal sinus tracts or history of basilar skull fracture can reveal the source of infection. For every CNS or in a systemic infection, you have to start with baseline investigations, general investigations, and specific investigations include CSF analysis, which include detailed reporting, gram staining or FB staining, cultures, gene expert, very important as for TB detection, PCR for specific organisms. Blood cultures are also important as corroborative tests in CNS infections. Specific serological assays, for example, in neurocephalus, HIVs are very important. Brain biopsy not routinely required, but sometimes, especially for example with fungal infection, you may need brain biopsy, or for example, inflammatory disease involving only brain, you may find some findings, for example, sarcoidosis. Biopsy of lymph nodes, skin, it's also not so much common investigation, but for example, leprosy and other infections, you can have biopsy of lymph nodes, skin lesions. Imaging studies, important is CT scan, screening study. MRI brain is very routine test nowadays, especially contrast study, not plain study, contrast study. And supportive tests, for example, chest x-ray, these are also important in detection of chronic CNS infections. So the most important chronic CNS infection, CNS tuberculosis. To start with, tuberculous meningitis arises from hematogenous spread of infection to the brain parenchyma, forming small tuberculomas that rupture into the subarachnoid space or ventricle in the initial weeks following airborne mycobacterial infections. So this is a common pattern of involvement in the brain with this pattern that we discussed, hematogenous spread. But less often there is spread from nearby infective sources, for example, otitis media or skull infection. In other patients, instead of subacute pattern of meningitis, after many years of asymptomatic infection, a ruptured tuberculoma. Tuberculoma is a localized cerebritis, then localized CNS infection with TB. It may remain asymptomatic, but may rupture sometimes with fulminant meningitis or acute meningitis because of rupture in subarachnoid space. So this can be presentation of CNS tuberculosis sometimes with acute meningitis. Strokes may result from vasculitis associated with the inflammation or exudative inflammation in the subarachnoid space. If meningeal fibrosis occludes the arachnoid villi, communicating hydrocephalus slowly develops, or if subependymal fibrosis interferes with CSF flow through the ventricles, acute hydrocephalus may also result. So commonly there is communicating hydrocephalus because of the meningeal fibrosis and exudative material accumulation and inflammation in subarachnoid space. But sometimes when there is CSF flow obstruction between the ventricles, you may have acute hydrocephalus or non-communicating hydrocephalus that requires surgical intervention. And this is just to show you how TB brain infection damages the brain parenchyma. My cursor is not working here. You can see vasculitis associated with TB that results in ischemic infarctions. You may see hydrocephalus development due to CSF outflow obstruction. You may see exudative meningitis, inflammation of the meninges. So, with TB meningitis, onset is acute, subacute, and sometimes it can be acute. Headache, vomiting, fever, bursts of irritability, anorexia, loss of weight, seizures can be sometimes presentation with headache and fever. And you may find various cranial nerve palsies, visual disturbances, and focal deficits like hemiplegia. Fever is a common finding associated with fever and some altered level of consciousness. You may on examination find signs of meningeal irritation like neck stiffness, kernings and Bruskin sign. You may find changes in the flexes with either exaggerated or sometimes decreased. Papilloedema on fundoscope. You can see cranial nerve palsies can range from visual disturbances, especially ophthalmoplegias with visual disturbances. Focal neurological signs you can find on examination, choroid tubercles, as you can see here on fundoscopic examination, formation of choroid tuberculosis on fundoscopic examination. So investigation most important is again CSF study, which shows high protein on DR testing and low sugars, and while increased WBC count with lymphocytic predominance, usually in hundreds. On smear with AFB staining, you can find in 25 to 40% of cases the positive AFB staining. Culture of CSF is important for TB meningitis for its detection as well as drug sensitivity. PCR, especially gene expertise is important, which is not mentioned here, which is routinely done for management point of view as well as detection. MRI brain with contrast may show meningeal enhancement, tuberculomas, hydrocephalus, abscesses, or sometimes infarcts. Very important test for detection of TB infection in the brain. Other supportive tests include chest X-ray, sputum FB. These are supportive tests. ESR to show the chronic inflammation going on. This is MRI brain contrast study T1 weighted images, which you can see here the avid fluid enhancement of the leptomeninges in brain stem, anterior to midbrain as well as posterior to midbrain in these subarachnoid spaces, which are called basal cisterns. So in basal cisterns, you will see there is fluid enhancement of the contrast anteriorly as well as posteriorly, and this is a very characteristic finding in patients with chronic TB meningitis infection. You may miss these findings, or patient may not have these findings if it is only loculated CNS infection with TB, for example tuberculosis or TB abscess. Anti-tuberculosis treatment for 12 to 18 months is routinely given. For TB meningitis, 12 months is sufficient. Sometimes with associated abscesses, tuberculosis, we may extend anti-tuberculosis therapy for 18 months. Similarly, initial phase, and for 2 months we give 4 drug therapy. Sometimes in majority of cases we replace ethambutol with streptomycin. because ethametol may cause visual disturbance, uptake neuritis, and in CNS infection you may miss the monitoring of visual acuity. So it's better to give streptomycin. In continuation phase, which may last for 10 to 16 months, you give only isoniazid and rifampicin, two drugs. Steroids in TB meningitis are very important, and for initial 4 to 6 weeks you must give steroids to decrease inflammation and to decrease the complication associated with inflammation in subarachnoid space. Tuberculosis and tuberculous abscess, as we discussed, it is parenchymal infection compared to that infection with TB in meninges or subarachnoid space. So it can be focal brain disease. The term tuberculoma describes a tumor-like mass that goes from intraparenchymal deposits of mycobacteria. These lesions, which can become calcified, comprise the most common focal intracranial mass seen in patients in developing countries. Most common focal intracranial mass, because TB is a common infection in our part of the world. You may find tuberculosis and tubercular abscess is the most common focal intracranial mass, common than your neoplastic and malignancies affecting brain. Tubercular abscess occurs when the center of a tuberculoma becomes necrotic and cystic. Basically, tubercular abscess is a tuberculoma which converts into abscess when its center becomes necrotic and cystic. Patients with tuberculomas present with seizures and focal signs, you can see here the difference. Because of the focal CNS disease, so patient not necessarily present with typical meningitis signs of chronic TB meningitis like neck stiffness and signs of meningeal irritation, so much headache. These may be present, but they may not be so much pronounced in this focal form of CNS brain disease with TB. Sometimes in case of multiple lesions, you may have increased intracranial pressure and diffuse cognitive dysfunction. Again, starting with routine laboratory investigations and CSF analysis may be completely normal in patient with tuberculosis or tubercular abscess, as it is a parenchymal disease and it remains encapsulated in the parenchyma. So if you draw CSF from subarachnoid space, which is basically covering of the brain, you may find only normal CSF. Sometimes you may find elevated protein concentration if the mass is near the meninges. And if the mass ruptures into the ventricles, for example, then you can have very typical marked pleocytosis and protein elevation, and as well as symptoms and signs of meningitis, acute meningitis. As it is a mass type lesion, so sometimes you need to go for stereotactic biopsy or surgical removal, which may show acid-fast bacilli. And PCR using gain amplification is also sensitive. Imaging studies, this is how the tuberculomas look like on MRI contrast study. For again, with tuberculomas or any mass, contrast study is preferred. You can see the lesions can be calcified, solitary, with enhancement patterns ranging from ring to diffuse. These are tuberculomas, all tuberculomas. Anteriorly, posteriorly, inferiorly, superiorly, supratentorial, infratentorial. Here you can see diffuse enhancement of the tuberculoma in pons, while posterior to pons, here you can see there's a ring enhancement. So it may be a ring type enhancement or sometimes diffuse enhancement, but these are all tuberculomas spread in the brain. It is a very common complication, hydrocephalus, because in TB meningitis as well as in multiple tuberculomas, when there's raised intracranial pressure, you can see hydrocephalus here, for example, with enlarged lateral as well as third ventricle. Again, antitubercular treatment is important for tuberculosis and tubercular abscess, while large lesions may require surgery, and sometimes with associated hydrocephalus, you have to go for permanent ventriculoperitoneal shunting. Important second infection that we will discuss, it is also bacterial infection spirochete, Treponema pallidum. Spirochetes are basically spiral-shaped bacteria, and the most notorious infection associated with them, chronic CNS infection, is syphilis. While syphilis can infect almost any body organ or tissue. So we will discuss about neurosyphilis specifically, but symptoms of both primary, the stages of syphilis, primary, it may be start with primary, secondary, and tertiary syphilis. And neurosyphilis is basically tertiary syphilis. There are four main clinical patterns of neurosyphilis. Patient may have asymptomatic neurosyphilis, patient may have meningovascular syphilis, tabes dorsalis, or general paresis. Primary syphilis, which occurs within 21 days of exposure and which is manifested by painless genital ulcer, chancre, and it can heal spontaneously in 3 to 6 weeks even without any drug therapy. So during this stage, asymptomatic CNS seeding may occur in 25% of patients. But if you identify this primary syphilis stage and treat patients with antibiotics, the chances of asymptomatic CNS seeding will decrease remarkably. The CNS may be involved at any subsequent stage of syphilis as well. For example, syphilitic meningitis, which occurs at any time after healing of the primary genital ulcer called chancre, it usually 4 to 10 weeks later may occur. During this stage, which is secondary syphilis, a highly variable, potentially infectious rash that tends to involve the palms and soles accompanies meningeal signs with photophobia and headache. Coming to tertiary syphilis, neurosyphilis, and its presentation. So meningovascular lesions, basically these are the strokes which occur in the setting of chronic meningitis in neurosyphilis. And this chronic meningitis may occur from 3 to 50 years after infection. As they cause basically strokes, so focal symptoms may progress over days, often after several weeks of headache or personality changes. These strokes occur because of the associated vasculitis in chronic meningitis of neurosyphilis. Tabes dorsalis, which is basically demyelination of the posterior columns, ascending columns, sensory columns of the spinal cord, and so therefore they cause various sensory symptoms like lightning, like Blake, leg pains, jabbing pains in the spine, gastric crisis, Lermet sign, which is very important sign of demyelination. Demyelination in the setting of tabes dorsalis, or demyelination in the setting of multiple sclerosis, which is a sign of and a feeling of electricity going down the back upon the flexion of the neck. In addition, patient may report impotence, urinary or fecal incontinence, and constipation. Position and vibratory sense are absent because of the damage in the posterior columns, as you know, that carries all these sensory sensations to central brain structures. Sensory loss also leads to joint destruction of the knees and ankles, so charcot joints may develop. Patient may have sensory ataxia and some difficulty or foot slapping gait. General paresis stage, which is advanced stage of neurosyphilis, which is basically dementia, cognitive decline along with complete paralysis. So symptoms of general paresis develop at least 10 years after infection in about 5% of patients with neurosyphilis. It doesn't necessarily develop all patients with neurosyphilis. 5% of patients with neurosyphilis may develop this stage, which is very advanced stage of neurosyphilis, in which chronic meningoencephalitis causes psychosis, dementia with poor judgment, manic behavior, led generalized paralysis. These symptoms may respond to antibiotics only if treated before atrophy and neuronal destruction. Once atrophy occurs in the brain, you cannot treat these symptoms with antibiotics or treatment for neurosyphilis. For diagnosis, important serological and CSF studies are done. The serological screening tests are of two types. So some are of antigen detection type and other are antibody detection tests. These antigen response tests, which include VDRL, venereal disease research laboratory and RPR, rapid plasma reagent, they basically use an antigen response that can be very sensitive but not specific. While these antibody assay tests, fluorescent treponemal assay, FTA, treponemal palladium heme agglutination assay, TPHA, enzyme linked immunofluorescence absorption assay, ELISA, these are more specific than VDRL or PCR, but they are more confirmatory compared to these screening tests, VDRL and RPR. So they are more specific tests. These are also sensitive, but they are not so much specific as these FTA, ELISA, and TPHA in serology. While in CSF, there is some reverse order, and CSF is not routinely done, but if there are neurological or ophthalmological signs, or if there is any evidence of tertiary syphilis, CSF analysis indicated. You may find on DR simple lymphocytic or monocytic pleocytosis, which can persist throughout the course of syphilis with several hundred cells. Sometimes glucose may be normal or mildly decreased. CSF protein concentration may be elevated, and oligoglobulin bands are often present in spinal fluid analysis and neurocephalus. VDRL of CSF is 100% specific, but 50% sensitive. So sensitivity of CSF VDRL is very less compared to serology, in which the sensitivity of VDRL is high, but specificity is very good. If you find VDRL in CSF, it is confirmatory. While FTA, which is antibody detection test, its specificity is only 30%, but it's almost 100% sensitive. So this is too low specificity for CSF FTA. So in CSF, more important is VDRL test. Coming to treatment of primary, secondary, and early latent infection of syphilis. It consists of only one intramuscular injection of benzathine penicillin only, one intramuscular injection. So it's very important to identify syphilis at primary stage. Or if you don't give intramuscular injection, you can go for 2 weeks oral doxycycline therapy in patients, especially those who are allergic to penicillin. Patients with latent syphilis or more than 1 year of duration, syphilis of unknown duration, and tertiary syphilis, they require the same dose of penicillin repeated each week for 3 weeks. So 3 doses of penicillin in later stage. Similarly, if they cannot, or patient have allergy to intramuscular injection of penicillin, you can go for oral doxycycline, but for prolonged duration, for 28 days. Here it was only 2 weeks. Neurocephalus, which is advanced stage of syphilis, and that is the chronic CNS infection that we are discussing now, it requires IV treatment with penicillin G every 4 hours for 2 weeks. Every 4 hourly for 2 weeks. So to achieve some bactericidal activity against treponema in the CNS. This stage you can't treat with only oral therapy. You have to give IV treatment with penicillin, neurocephalus. Now coming to fungal infections. After common chronic CNS infection with bacteria, fungal infections are also common, especially Cryptococcus neoformans is the most common pathogen, followed by Candida, Coccidioides, Cytoplasma. Most cases of cryptococcal meningitis represent re-emergence of existing infection in immunosuppressed patients, especially those with AIDS, when CD4 count falls below 200 cells. CD4 count is what basically these are T cells which are progressively dropped in case of patients with HIV infection who develop AIDS. So the more the CD4 count drops, the more serious fungal infection occur. Other causes of immunosuppression, such as use of anti-rejection drugs, organ transplant recipients, in patients with chemotherapy-induced neutropenia, diabetes mellitus, malignancy, chronic alcoholism, who use steroids for chronic diseases, patients with pregnancy or prematurity, they are all conditions It is very important list of conditions which may cause immunosuppression and leading to occurrence of fungal infection. Fungi are ubiquitous, existing in the form of either molds or yeast, and their spores are inhaled or they invade the skin, mucous membrane, sinuses, or wounds. So common clinical features associated with fungal CNS infection: headache is a common infection. Meningeal signs, fever, and altered mental status are usually less frequent and less pronounced in fungal infection than in bacterial or tuberculous meningitis. Also, encephalopathy is found. So meningeal signs may be found in fungal infection, but they are not so pronounced in fungal compared with TB and bacterial infections. Coma in fungal infection that implies very severe intracranial hypertension, hydrocephalus, or hyponatremia due to inappropriate antidiuretic hormone secretion. You may find papilledema on fundoscopy, diplopia, and focal signs. Candida, aspergillus, and rarely blastomycosis infection cause microabscesses or microhemorrhages. So this slide is showing in brain different fungi may present in different form. Mucormycosis. This is very common clinical presentation in neurology department. Basically, mucormycosis occurs in the setting of immunocompromised status, especially with diabetes. And in neutropenic or diabetic patients, especially those with hyperglycemic ketoacidosis, this fungal infection causes orbital cellulitis and nasal destruction, followed by cavernous sinus thrombosis and frontal abscess that is highly necrotic. Commonly, we see in our setting this nasal infection and ultimately destroying the nasal bones and causing CNS invasion, invasive mucormycosis, especially those in diabetic patients or those other with immunocompromised status. Aspergillus can produce sudden focal symptoms, especially as a result of hemorrhage into a mass. Coccidioidal meningitis is difficult to treat and has high significant morbidity and mortality. Laboratory findings: you will find on CSF-DR elevated proteins, normal to low glucose, increased WBC count with lymphocytic predominance. Sometimes in coccidioidomycosis, they may produce eosinophils or neutrophils in CSF. So neutrophil predominance can also be found in histoplasmosis, blastomycosis, different fungi means. You may find encapsulated organisms on smear with India ink cultures in cryptococcal meningitis. Here you can see encapsulated cryptococcal organisms on India ink staining. These antigen antibody detection tests, latex agglutination, radioenzyme immunoassay are sometimes also used to confirm the diagnosis with different fungal infections. Cultures are important fungi. Biopsy is the gold standard test. If you can perform biopsy, it's almost diagnostic with 100% accuracy, especially in very invasive brain disease. Hydrocephalus, which is caused by ependymitis or blockage of subarachnoid space, is a complication in fungal infections, and you can find this on imaging studies, especially with MRI, CT scans. You may find meningeal enhancement, as we saw in tuberculous meningitis, in fungal meningitis, also in basilar meninges. You may find small areas of mass cryptococcoma, which can be present adjacent to ventricles. So different fungi present with different MRI findings. MRI with contrast can also reveal candidal multiple abscesses or hemorrhages, microabscesses or microhemorrhages with candida. So hemorrhage is a common finding in patients with aspergillus infections, necrosis with zygomacies, and sometimes blastomyces infection causes epidural abscess as well as intracranial abscess. Different fungi present with different imaging studies. This is not very necessary for you all to remember these things. You must understand the pattern of involvement in fungi and TB and bacteria. This is, I think, probably something advanced at fourth year MBBS level. These are the images of plain images of MRI brain. This is T1 image. This is T2 image. Here you can see hyperintensities involving basal ganglia, caudate nucleus. hyperintensities here, as well as hyperintensities involving this gray matter cortex. These are, you can see on plain studies MRI with Cryptococcus infection, which is infection of the CNS in an HIV positive individual. Here you can see again hyperintensities on T2 weighted images. T1 weighted images are these because CSF is black. This is T2 weighted image of MRI which shows white CSF. On this T2 you can also see these hyperintensities in hyperintensities here in white matter of the brain, while here white and gray matter of the brain. So there is hyperintensity involving right parietal cortex, while you can see these hyperintense lesions in cerebral aspergillosis as well. Again, this is a complication of immunocompromised patients. Antifungals are used for treatment of invasive fungal disease, especially amphotericin is important to use IV amphotericin in case of invasive fungal disease. While you can use fluconazole, ketoconazole, itraconazole, they all basically work by disrupting fungal cell membrane. After initial treatment with these antifungal IV treatment, invasive treatment, you have to give a maintenance therapy with antifungal fluconazole, which is continued until CD4 count becomes higher, especially more than 100. Along with antifungal therapy, you have to give supportive treatment for raised intracranial pressure, for hydrocephalus. For example, patient may require ventriculoperitoneal shunting. Toxoplasmosis parasitic infection, again, this is a very leading cause of focal CNS disease, especially in patients with advanced HIV infection, when CD4 count becomes less than 200 cells. Greatest risk is in patients with CD4 count less than 50. It's almost always due to reactivation of old CNS lesions or to hematogenesis spread of previously acquired infection. Occasionally, it results from primary infection. Fever is usually but not always present. Early patient may present with headache and constitutional symptoms. Later, patient may develop confusion, drowsiness, seizures, and focal weakness and other focal disturbances. Here you can see multiple ring enhancing lesions or ring enhancement like we saw in tuberculosis. But again, presence of, if you are suspecting toxoplasmosis, presence of serum toxoplasma IgG antibody is very important and diagnostic, along with these MRI ring enhancing lesions in brain. So you have to correlate clinical and radiological findings for detection or for diagnosis of toxoplasmosis, and patients may usually improve with pyrimethamine and either sulfadoxine or clindamycin combined with pyrimethamine. HIV is a very important cause of chronic CNS infection, not itself, but because of immunocompromised status, patient may develop chronic CNS infection with many other organisms because of the immunocompromised status. At least 1/3 of those with HIV/AIDS are afflicted with an HIV-associated condition. So it depends on the CD4 count in early stage of HIV infection, which is CD4 count more than 500. CD4 count, as I discussed, basically these are the T cells, WBCs, in which HIV there's a progressive decrease in CD4 count. In early stages, which is CD4 count more than 500, you may have central infections with HIV meningitis. Basically, it's not so serious condition. You may have shingles, you may have AIDP, which is acute inflammatory demyelinating polyneuropathy. Middle stage, when CD4 count is between 200 and 500, these conditions can be found to involve your nervous system. In late stages, a very serious stage, when CD4 count drops less than 200, you may have very serious CNS infections as well as other conditions like we discussed now, CNS toxoplasmosis, various fungal infections that we discussed, cryptococcal meningitis, progressive multifocal leukoencephalopathy, PML, primary CNS lymphoma, HIV-associated myelopathy, varicella zoster vasculitis. HIV meningitis is self-limited monophasic aseptic meningitis which occurs during primary HIV dissemination as part of the acute conversion syndrome or less commonly after cessation of antiretroviral therapy. HIV is believed to be directly causing meningitis. Sometimes encephalitis may accompany the meningitis in HIV meningitis. CSF meningitis are consistent with aseptic meningitis with a lymphocytic pleocytosis of 200 to 300 cells. HIV DNA can be amplified in the CSF, although its presence does not exclude other coincident causes. MRI may show enhancement of the meninges. Serum HIV test will usually still be negative because of acute conversion syndrome and that this meningitis is associated with. No specific treatment for meningitis is recommended when encephalitis is present. Encephalitis is basically parenchymal infection. When you see there is associated encephalitis, you have to start acyclovir unless herpes simplex virus encephalitis is ruled out. And when there is encephalitis associated with meningitis, you may consider starting treatment with CNS penetrant antiretroviral agent. Cytomegalovirus is a devastating infection. Again, it's a viral infection that occurs in the setting of advanced HIV disease. It is a devastating infection that occurs in the very late stages of AIDS with CD4 count less than 50. Sorry. But it's now rarely seen in patients with HIV. On CORT. CORT is basically combination antiretroviral therapy. Patients with antiretroviral therapy usually they're less likely to develop cytomegalovirus infection, but the patients will develop this virus infection. This is very devastating form of encephalitis. Two forms of encephalitis have been described, either ventricular encephalitis, which is more common, or micronodular encephalitis. So typical CSF profile in cytomegalovirus shows mild to moderate monocytic pleocytosis, elevated protein and low glucose levels like other viral infections. CSF is very important. CSF PCR is very important for viral fungal infections with cytomegalovirus DNA, which is very sensitive and specific. Combination of IV ganciclovir and foscarnet for 3 to 6 weeks is very important in case of cytomegalovirus infection. Lifelong maintenance therapy with ganciclovir orally and foscarnet should be provided after IV treatment. Consultation with infectious disease expert is very important. Prognosis is very poor in case of cytomegalovirus infection in advanced HIV infection. Progressive multifocal leukoencephalopathy is also again a late stage complication of HIV infection in which a reactivation of JC virus occurs, and usually the CD4 count is less than 100, and there is subacute evolution of focal neurological disease and dementia because of demyelination of white matter. Progressive multifocal leukoencephalopathy basically is a white matter disease in which the white matter sheath, which is myelin sheath, formed by oligodendroglyocytes, it is infected by these JC viruses, and so they cause demyelination of the white matter in the brain, which you can see on MRI, and it leads to focal neurological disease as well as dementia. CSF usually remains normal, but you may find PCR CSF with JC virus sensitivity of more than 90%. MRI is very diagnostic in case of these infections, progressive multifocal leukoencephalopathy, in which you will see subcortical white matter disease. Here, as you see subcortical white matter disease on this is a T2 image, and this is again T1 image with black CSF, white CSF. This white matter, gray matter, white matter, you see these hyperintensities involving bilaterally. Here, also white matter is annulled because of the JC virus infection with oligodendroglyocytes causing demyelination. So this subcortical white matter, these white matter signals on MRI are very diagnostic for in proper clinical setting for this progressive multifocal leukoencephalopathy. Treatment is basically combination antiviral therapy. No specific treatment for JC virus, but you have to give antiretroviral therapy for AIDS, HIV. Subacute sclerosing panencephalitis, SSPE, which is progressive encephalitis, and it is caused by a defective measles virus. People also found this infection commonly presenting, and we have many presentations in our department with this chronic CNS infection as well. Basically, symptoms occur in children, and usually after 6 to 8 years of primary infection. There is a rapidly progressive cognitive decline, ataxia, and myoclonic jerks. In the later stages, patient become bedbound, and patient become bedbound in a state of spastic akinetic mutism. Measles IgG antibodies in CSF usually confirms the diagnosis. EEG shows generalized slowing pattern, and treatment is basically symptomatically for these epilepsies. Otherwise, there's no curative treatment. Complication of CNS infection with systemic complications, patients can have cardiopulmonary failure, hyponatremia, GIC, arthritis, endocarditis, myocarditis, loss of deterioration in the consciousness because of cortical involvement, seizures, and hydrocephalus may occur. Other neurological complications with vasculitis leading to infarcts and strokes that can be arterial strokes as well as venous. Patient may have brain abscesses, specific focal neurological deficits with cranial nerve palsies, for example, with 8th cranial nerve, 6th cranial nerve, 3rd and 7th, 2nd cranial nerve. Patient may have speech problems, aphasia, other focal neurological deficits like hemiparesis and quadriparesis. Hydrocephalus is a very common complication of chronic CNS infections. As you can see here, the enlargement of ventricles, lateral as well as third ventricle, and here frontal horn, the lateral ventricles, these are enlarged because of the raised intracranial pressure, and it is usually due to basal meningitis. Basal meningitis leading to CSF flow obstruction and the accumulation of the fluid within the ventricles causing ventricular dilatation.